Okay, good morning. Welcome everyone. My name is Ninka Zomerdijk. I am a member of the PoCoG Scientific Committee and the organising committee for this year's scientific meeting. And I'm delighted to be chairing this meeting today on studies in COVID-19. So first of all, I'd like to acknowledge the unique position of Aboriginal and Torres Strait Islander people in Australian history, culture and society. And I would like to pay my respect to their elders, both past and present, and extend that respect to other Indigenous Australians online today. So before we start today's presentations, just a few housekeeping notes. Today's event is being recorded and it will be made available on the PoCoG YouTube channel, where you can also view previous webinars. And if you do have any questions for today's presentations, you can do so via the Zoom Q&A function. And we really encourage you to submit your questions throughout the presentations, and we'll aim to answer your questions throughout the session. So moving on to today's topic, it's kind of crazy that it's been not only one, but nearly two roller coaster years since the pandemic first began. And of course, it's created significant challenges for everyone, both personally and professionally. But we know that those challenges haven't spread evenly across our population, and some groups have been more affected than others. And this, of course, includes people living with cancer, their caregivers, and the healthcare workers who care for them. And today I am joined by 6 wonderful researchers and clinicians who have dedicated their work to uncovering these challenges, but also the opportunities that have been presented by the pandemic. And it is our hope that these presentations will provide you with new knowledge that you can apply both in your research and clinical practice, and perhaps also some new questions that remain to be answered. So on that note, I'd like to introduce to you our invited speaker, Associate Professor Natalie Taylor. Natalie is a health psychologist and implementation scientist at the University of New South Wales, and her program of research focuses on developing and advancing methodologies to find the best ways to translate evidence into clinical practice. And we're delighted to have Natalie joining us today, and she'll be presenting on cancer care disruptions during a pandemic in Australia from a patient, carer and healthcare worker perspective. Thanks, Natalie.
Thanks, Ninka. I'm just going to share my screen and check that you can all see what I want to see. Not one. Do I need to switch the display?
We can actually see your, yep, that's good.
Perfect. Okay, well, hello everyone. I don't know whether you can hear me okay or not, because I can't see anybody or anything anymore, but
it's good, Nat.
Thank you, great stuff. So welcome to this presentation today on the psychosocial evaluation and assessment of cancer communities and healthcare workers during COVID-19, or HC19 for short. Thanks to PoCoG for inviting me to talk to you today. I'd like to begin by acknowledging the traditional owners of the land which we meet today, which for me are the Gadigal people of the Eora Nation, and pay my respects to elders past and present. The COVID-19 pandemic continues to have a significant global health impact, but particularly on people living with cancer, their families and carers. It's also affecting the delivery of cancer services and the healthcare workers employed in these settings. Today I'll present 2 studies exploring insights from the cancer community and healthcare worker perspective during the first year of the pandemic. At the time of this study, we were a team based together at the Cancer Council New South Wales. The faces you see were the team on the ground behind this project and supported by our internal collaborators from Cancer Information and Support Services, Cancer Prevention and Advocacy, marketing and comms and IT, as well as our academic collaborators from the University of Sydney. A couple are on the panel today, Macquarie University, UNSW, and consumer and clinical partners, who I'll introduce a bit later on. And the first section of the presentation will share our real-time insights of the psychosocial impacts of COVID-19 on Australian cancer patients, survivors and carers. And to facilitate the exploration of this research aim, we worked with two of Cancer Council New South Wales' most utilised supportive care services. The 13 11 20 information and support line captures incoming calls from New South Wales and the ACT. Anyone can call Cancer Council 13 11 20, where specifically trained staff are available to answer questions about cancer and offer emotional or practical support. And the Cancer Online Community, Cancer Council Online Community, which is an Australian-wide online forum in which people can join for discussion. This is an Australia-wide service, and the members of the public can join to receive and provide peer support. Our study was inclusive of the period between the 1st of December 2019 to the 31st of May 2020, using the 13 11 20 and the online community. We assessed real-time demands on service trends, distress thermometer data collected as part of the minimum data set, reasons for calls as indicated by the consultants and the consultant call notes. And for the Cancer Council online community, we assessed service demand trends and discussion post content. We identified relevant calls through call notes and online posts using search terms associated with the pandemic. And once we identified data relevant to the pandemic, we conducted an inductive conventional content analysis with the 13 11 20 calls, identifying emergent themes and developing data-driven needs-based recommendations. We used qualitative codes generated from the inductive content analysis to conduct a secondary deductive directed content analysis with online posts made to the online community, further refining our emergent themes and recommendations. We were able to provide demographic characteristics from callers to the 13 11 20 service, but these data are not available from participants in the online community. Callers to 13 11 20 who cited concerns with COVID-19 during the study period were predominantly cancer patients aged 60 to 69, and 39% of callers were experiencing their first cancer diagnosis, and the main reasons for calling, as directed by consultants, were for psychological and emotional support. The chart shows the number of calls to 13 11 20 regarding COVID-19 and page views on the COVID-19 online community page over the study period, noting that before March 2020, the volumes of calls and page views were very small. COVID-19 related calls and page views peaked as virus control restrictions were first mandated by the Australian government at the end of March 2020. These restrictions include limitations on the gatherings to a maximum of 2 people, 14 days overseas quarantine, and the banning of non-residents from entering Australia. Throughout April and May 2020, demand gradually tapered, but we started to see noticeable shifts in the types of issues discussed on the calls, moving from general information requests to a greater proportion of calls about psychological and emotional well-being. And this trend was also reflected when we analysed the distress thermometer data. And as you can see from this chart, whilst overall service demand may have tapered between March and May 2020, distress levels on COVID-19 calls increased over time, peaking at a median 8 to 10 in May 2020, 8 out of 10 in May 2020. Anecdotal feedback from the consultants also confirmed this trend in increasing caller distress. We also compared distress over the study period to overall calls to 13 11 20 during an equivalent time period in the 2019-20 financial year, and found that medium distress was higher, with a median of 7 compared to 6 for all calls. Our qualitative content analysis shaped 5 emergent themes, many of which were overlapping. Psychological distress and fear of virus susceptibility was mentioned in more than half of the calls we analysed, and a third of online posts. Callers and online posters reported anxiety about whether their current or previous treatment placed them at an additional risk of severe or fatal illness should they contract the virus. They also spoke of the effects of isolation and the changes to their regular social networks and support systems. Practical issues included factors such as increased financial hardship, employment difficulties, transport issues, and difficulties accessing essential items or services. Some patients faced challenges attending treatment due to the cancellation of community transport services, and others mentioned how distress was heightened when they could not access items due to temporary shortages or the high demand of other online services. Disruptions to cancer and treatment were identified frequently, including rescheduled or cancelled appointments or surgeries, or shifts to telehealth consultations. And in some cases, these disruptions caused uncertainty, fear around disease progression, and they questioned whether the virtual delivery of healthcare would be of the same quality. Worryingly, in some instances, patients had self-elected to cancel their checkups or appointments due to the fear of attending treatment centres during the outbreak. Information needs. So callers and posters described how the current information and guidance for cancer patients was inconsistent and unclear. They were unsure as to the precautionary measures that they should be taking and the protective equipment they should wear in public. Carers also sought advice on information around how to best safeguard their loved ones, whilst balancing their responsibilities for providing essential care and support. And one of the main sources of distress for carers was the visitation restrictions and limited opportunities they had to provide care and support if living in a separate household. It was particularly distressing for carers if they were unable to see someone with an advanced cancer diagnosis or whom were receiving end-of-life care. And so major cancer service disruptions, the deepening economic crisis, and the lack of social connectedness are amplifying these impacts in this vulnerable population. The disruptions are likely to be enduring and have lasting consequences, and have the potential for direct and indirect impacts and clinical outcomes, which I'm sure we'll see presentations on today. We've recommended a set of evidence-based recommendations to address support, access and information needs, offering flexible and adaptable strategies for cancer care throughout and beyond the pandemic. Ongoing assessment is critical to shape these recommendations as new restrictions and policies emerge. Building on the insights from this first study, our team launched an Australia-wide study, Peach C19, to further explore the psychosocial impacts of the pandemic on cancer patients, survivors and carers and healthcare workers involved in the delivery of cancer services. So this nationwide study aimed to understand the psychosocial impact of the pandemic for cancer communities and learn how it affected cancer care delivery to subsequently drive the design of relevant support mechanisms and interventions both during and after the evolving health crisis. So insights around the impact of COVID-19 from the real-time data set that we analysed were carefully analysed, and the themes that emerged were used alongside a range of validated tools to provide the foundation for the two surveys developed for this project, to ensure they included questions that were relevant and meaningful to cancer communities and healthcare workers regarding the COVID-19 impact. Crucially, we collaborated with members from our Cancer Information and Support Services Division, our consumer Catherine Lane, and clinical partners working in cancer care to co-design our study materials and maximise the impact of the research. We used a range of strategies through our organisational, community and clinical networks to recruit patients, carers and healthcare workers to the study, and our tracking system helped us to see which methods were most effective for bolstering recruitment. The first study asked cancer patients and carers about access to diagnostic tests and treatments, views and experiences of telehealth services, health behaviour change and psychosocial impact. And our healthcare worker survey was designed with a broader focus so that the tool might be used to understand the impact of a range of crisis events on cancer services in the future. And themes include preparedness for crisis and organisational resilience, cancer care delivery, positive changes to healthcare delivery and response and recovery strategies needed. We also incorporated some of the tools that the members of the UICC Global Task Force used in other countries so that international comparisons might be possible down the track. Today, I'll present results focusing on some of the most striking findings from the patient survey and bring in some interesting complementary results from the carer and healthcare worker survey in relation to care disruption and telehealth. We aim to identify perspectives across the groups which speak to similar themes to drive the focus and design of relevant and meaningful interventions that address key areas synergistically. So a total of 683 cancer patients and survivors completed the survey. The majority of them were women aged between 55 and 74 living with another person in metropolitan areas. We have representations from all states and territories, but 77% of our participants were from New South Wales. 38% had received a cancer diagnosis in the last 2 years, and there was a relatively even spread of the participants across different cancer stages, including those in recovery or remission. 30% indicated they were not receiving any active treatment at the moment, and some of the treatment options included anti-hormone treatment, chemotherapy and surgery. The most common type of cancer was breast, followed by prostate and colorectal. Survey responses were also collected from 169 cancer carers, families and friends. Most of them were caring for a partner or parent with cancer, and about half provided care on a daily basis and lived with the person with cancer. For the healthcare worker survey, I personally pledged to donate $100 for every 100 surveys completed, given how difficult it normally is and at this particularly difficult time to recruit this population. We received 150 responses, so I donated $100 after the survey had closed. The responses represented doctors, nurses, trial coordinators and allied health professionals. 86% of them had direct clinical interactions with cancer patients, and the most common settings were inpatient hospitals, outpatient services and cancer treatment centres. The impact of COVID-19 on psychosocial well-being was measured using several validated scales. And for cancer patients and survivors, psychological distress significantly increased from 2.8 before COVID to 4.8 since the outbreak. Scores on the 4-item patient health questionnaire suggested more than 20% of participants showed current indication of anxiety and depression. Since the start of the pandemic and the subsequent social distancing restrictions, there was also a significant increase on the CLA loneliness score, indicating increased findings of loneliness and social isolation. A quote from a participant's comment said that they were more depressed by being socially isolated during this time than through any of the 4 cancer diagnoses and treatments. Furthermore, 8 out of 10 cancer patients and survivors reported concerns regarding their risks of exposure to the virus. In terms of the financial and practical impact, 40% of cancer patients experienced some level of income loss and changes in employment. There was a significant increase in financial distress felt by participants since the pandemic, and some expressed concerns about their future employment, abilities to afford living expenses such as groceries, transport and rent, as well as difficulties with shopping for essential items. For cancer patients and survivors, higher levels of psychological distress were significantly associated with being female, having a prior mental health condition, receiving active treatment, experiencing cancer care disruption, greater financial distress and higher baseline distress levels. And greater loneliness was significantly associated with being female, having fewer people in the household, having a prior mental health condition, cancer care disruption, greater financial distress and higher baseline loneliness. In addition, more than half of cancer patients and survivors had said they exercised less and slept less well since the pandemic. About 3 out of 10 also reported decreases in the quality of their diet and frequency of attending routine health appointments. Alcohol consumption has increased for some but decreased for others, and little change was seen in smoking habits. Consistent with the results of cancer patients and survivors, carers and families have also reported increases in psychological distress, feelings of loneliness and isolation, financial distress, and decreases in health behaviours. For carers, psychological distress was negatively associated with age, time since cancer diagnosis, and being retired, but was positively associated with financial distress. Compared to those caring for a partner or spouse, participants caring for a parent or other family member with cancer reported significantly higher psychological distress. Carers living in a separate household to the person with cancer also reported higher psychological distress than those who lived together. And greater loneliness amongst this population was associated with greater financial distress, caring for a parent with cancer and not cohabiting with the parent with cancer. Those caring for someone with localized, regional or metastatic cancer are experiencing greater feelings of loneliness compared to those caring for someone in recovery or remission. We also looked into the impact of COVID on cancer care delivery and health services. So overall, 42% of cancer patients and survivors reported experiencing some level of care disruption. 15 to 30% of patients had to reschedule their cancer appointment, treatment, surgery and screening. And a small proportion also experienced cancellation of their care, including clinical trials. The quote from a patient living in rural New South Wales illustrated what it was like to navigate the changes and delays in cancer diagnosis, treatment and consultations during the pandemic. According to healthcare workers, about 75% of them were happy with the quality of the care they were able to provide and felt they were able to answer patients' questions about the impact of COVID-19. However, most of them also expressed concerns about the impact of the pandemic on cancer patients' mental health, the challenges involving carers and consultations, and the increase in the complexity of care. About half of them were also concerned about the delays in care delivery, cancellations of appointments, and the decrease in patients' access to clinical trials. One of the significant changes in care delivery was the shift to telehealth services, as we saw 74% of patients using telehealth compared to just 17% before COVID. And over half of them said they were likely to use it again in the future. The overall experience of telehealth for cancer patients was mostly positive. The main areas of concern were the psychological and emotional support received and the issues with technology and internet access. Although the findings suggest the benefits of telehealth seem to outweigh its difficulties, there were a few comments from patients about the issues they have experienced with telehealth consultations. And almost 48% of carers reported they had been unable to attend telehealth consults with the person diagnosed with cancer. They described how not being able to attend appointments, whether in person or via telehealth, had placed an additional burden on them to provide the same level of practical and emotional support as before the pandemic. Some carers suggested that they were no longer able to listen to and clarify important information for their loved ones, nor understand how they were best able to provide support during intensive treatments. Patients also highlighted the lonely experience of attending appointments with a reduced social support network. They felt overwhelmed attending cancer treatments alone and described challenges with digesting and interpreting health information from clinicians without this additional support. The ultimate aim of this work was to identify key areas and relevant evidence-based interventions that can be designed to support cancer patients and carers and healthcare workers and the health system as they recover from the pandemic and build resilience ready for any future crises. Results have been translated into key recommendations for cancer care in Australia to enhance healthcare system preparedness and resilience should future crisis events occur. 486 participants did consent to follow-up research, we did hope to reach out to do more qualitative work, combining these deeper insights with our quantitative findings to further drive and refine intervention design, but we have not yet commenced this piece of work, mainly due to limited resources. So please reach out if you're interested. Our starting point would, of course, to be identify any existing Cancer Council New South Wales programmes and services that could benefit from this nationally representative insight. We won the Public Health Research Award category for this piece of work at the Australian Public Health Conference. We were so thrilled and hope the insights can help to drive the next stage of this research to generate meaningful and relevant change for cancer patients, carers and healthcare workers. Thank you for listening. Just trying to stop sharing now. Have I stopped sharing yet? No. Sorry.
Thanks, Natalie. It's an incredible amount of work you've done, and thank you for sharing your knowledge and insights from the research you've been conducting over the last 2 years. There is a question here from Vanessa Barrett, who's asked whether you could clarify what the concerns about psychological support were under the difficulties with telehealth.
Yes. What I might do, if it's okay, is I might refer you to the paper that's been recently published. I think it's in PLOS One, and we have a table that outlines the patient and carer and healthcare worker concerns around telehealth in general, and there's some specific elements around psychological support concerns that are listed in there, if that's okay.
Great, thank you. And another question here from Kate White, who's asked, did you identify any positive changes that occurred during this time?
I think it's kind of going back to telehealth, really. I think people, actually switched and adapted willingly, which I think, I guess anecdotally and from other research that we've done in the past, it's generally shown that telehealth hasn't necessarily taken off as well as it should. And so I think I guess people were forced in this situation to move to telehealth, but actually a number of people said that they were very likely to use it again. I guess it's really just unpicking the kinds of consultations that really are appropriate for telehealth-based support versus those kinds of consultations, whether they're very physical or really do require psychological support that maybe can't be delivered without it being face-to-face.
Great, thanks, Natalie. And one other question here from Kate White. How does the increase in psychological distress among cancer patients compare with the increase in distress in a general population?
That is a good question. I'm not sure. I guess the only comparison that we were able to provide was the distress score from cancer patients and carers in the 13, 11, 20 calls from the entire year before, which on the whole jumped up from a 6 to a 7. But it may be in the paper, but I can't recall off the top of my head what a general population distress score would normally be. It's quite a hard sentence to say.
Great, thank you. And I've got a question myself, actually. Did you find any differences based on the states that participants resided in? So, in light of the fact that there were different restrictions in place during that time?
Yeah, so I think we did notice some differences in the qualitative data between Victoria and New South Wales, but there was still not really, I would say, a representative enough sample to do any meaningful quantitative analysis between states, although that would have been really nice to be able to do, particularly as Victoria went through such a I guess a much more difficult an extended period of restrictions and lockdown. Having said that, I think that the period of time we collected the data for as well, I guess Victoria, it kind of went on beyond that in terms of their prolonged experience of lockdown and restrictions. So it would have been really handy to have continued to collect that data. I think Cancer Council Victoria are actually interested in repeating this study in Victoria, kind of, I guess, to look at that prolonged impact.
Yeah, it'd be very interesting. Well, thanks again for your time, and thanks for sharing all your wonderful knowledge on this topic. So we're going to move on to the next part of our program, which involves a series of 5 excellent presentations. And again, encourage you just to send through your questions throughout the presentations, and we'll take some time after each presentation to answer those questions. So I'd like to introduce to you our second speaker, who is also well known to us in PoCoG, Dr. Nicole Bartley. Nikki is a research officer with PoCoG and also a lecturer in research methods at the University of Technology, Sydney. And today she will be speaking about the perspectives of cancer patients, carers and healthcare workers regarding COVID-19 vaccination.
Thanks, and good afternoon, everybody. So today I'll be talking to you about the experiences and perspectives of cancer stakeholders, specifically about the COVID-19 vaccination, and presenting findings from a qualitative study. So we are all aware of COVID-19 and that the vaccination is a key strategy in combating the virus. People with cancer were not overly included in the clinical trials during vaccine development, and so therefore there's not really a lot of evidence about the safety of COVID-19 vaccines for people with cancer. Despite this, many of cancer organisations internationally recommended vaccination for cancer patients, as they are particularly vulnerable to developing COVID-19 and having severe infection. And these recommendations were really based on the evidence from other vaccines, and that this vaccine would likely be safe for cancer patients as well. So we wanted to explore cancer patients, their family members, oncology health professionals and non-government cancer agencies' views on the COVID-19 vaccination in Australia. So we conducted semi-structured interviews at 6 months and 12 months post-recruitment with adult cancer patients who were currently receiving or within 6 months of treatment, their family members, oncology health professionals, as well as representatives of cancer non-government organisations. We recruited our participants through email invitations to professional or consumer organisations, through 2 hospital-based oncology services, and we also used snowballing for our health professionals. The data collected was coincided with the second wave of COVID in New South Wales and the ACT, and Victoria's third wave. So the majority of our patients were female from New South Wales, married, university educated and retired. Our patients had a mean age of 58 years and were mostly breast or prostate cancer patients. 35% had been diagnosed in 2020 and 28% had metastatic cancer. Our family members were mostly female as well, with a mean age of 60 years. They were also mostly living in New South Wales and university educated. 90% of our family members were the spouse or partner of a patient, and 60% had their own medical condition. Our oncology health professionals were female with a mean age of 51 years. Most were located in New South Wales and were nurses or cancer care coordinators. Similarly, the representatives from NGOs were female with a mean age of 45 years, located in New South Wales and Victoria, and were also nurses or cancer care coordinators for the most part. Thematic analysis of the interview transcripts revealed 6 main themes that were present across the 6 and 12-month interviews, and these included high motivation, hesitancy, uncertainty, confusion and frustration, accessibility, and expert individualized advice. So overall, our stakeholder groups expressed pro-COVID-19 vaccination attitudes and were eager to be vaccinated. As you can see from this patient quote here, as soon as it's available, it's getting done. This attitude really stemmed from feelings of social responsibility, a sense of hope, and a desire for safety and protection from COVID-19 transmission. By 12 months, all our interviewees were vaccinated, at least partially, and expressed feelings of protection and also a sense of relief. As you can see from this family member here, it was much more scary before he had got the vaccination. A few participants did initially express hesitancy about the vaccine at their 6-month interviews. And this was largely due to a belief that COVID-19 is a conspiracy, a perception that not enough research about the outcomes of the vaccine, and a fear of side effects. So this patient's quote nicely sums that up. She didn't want to get the vaccine. She was already on targeted therapy and they don't really know the side effects of that. So how are they going to know the side effects of the vaccine with her targeted therapy? Some people acknowledge that they were late adopters more generally, and that carried over to this vaccine. And some patients were advised by their health professionals to put off vaccination. So even though our cohort was vaccinated at the 12-month interview time point, some health professionals estimated that there was still a small percentage of patients who in the broader community that was still hesitant. Hesitancy was initially expressed by only a few participants, and most of our interviewees were actually more concerned and angry with vaccine hesitancy in the wider community. And you can see this family member's quote here: "I don't understand anti-vaccination, that bewilders me." So across our participant groups, there was confusion and frustration related to the disorganised and delayed vaccine rollout. And this health professional states here, the national vaccine rollout has been woeful in the extreme, and the whole country is in lockdown now because of our poor vaccination rates. Participants discussed frustration and confusion in regards to understanding vaccination priority groups, about receiving conflicting advice from their health professionals, so GPs and specialists conflicting advice about whether to have the vaccine, and also about how the media had communicated the AstraZeneca vaccine and blood clots, and how that had generated misinformed fear in the public. Across our groups, participants experienced uncertainties related to eligibility, how to access the vaccine, whether cancer patients were at increased risk of side effects, whether the vaccine was effective in cancer patients, and if there would be treatment implications. And you can see this health professional here was talking about having received lots of queries about the timing of vaccinations with treatment and whether or not treatment would need to be delayed by having the vaccination. There was also uncertainty about the long-term efficacy of the vaccine. Some of our interviewees experienced quite easy, streamlined access to the vaccine, but there did appear the 6-month interviews to be a lack of urgency from health professionals to have patients vaccinated, and really a prioritisation of the flu vaccine over the COVID vaccine, which is nicely captured by this patient's quote here, where she's saying that her health professional had told her that the flu vax was much more important than the COVID vax at this time point. Our patients discussed a perceived lack of choice around which vaccine was accessible for them, but most of them were willing to accept any vaccine. And as you can see from this patient here, she's saying she got Pfizer in the end and she was happy about that, but she would have had the Astra because she just wanted to be vaccinated. While some of our patients had no concerns about the vaccine and didn't discuss vaccination with their health professionals, others really wanted expert-tailored advice. So our patients considered oncologists, GPs, and other cancer patients as trusted sources of information. And allied health professionals were referring patients to their specialists, and health professionals in general were referring to trusted resources like Cancer Australia, cancer councils, and ATAGI. Health professionals did feel confident talking to their patients about vaccines and had been provided directive from their organisations to be evidence-based and pro-vaccination. And you can see this health professional down here speaking about she'd been advised that they have a responsibility to promote vaccination as good. So this is a table of the information needs that were identified by participants throughout the interviews, and they really wanted information on accessibility and eligibility. So how and where to access the vaccine and whether or not cancer patients were a priority. They wanted information on the risks from having the vaccine versus getting COVID, the risk of side effects, and in particular, how other cancer patients had responded to the vaccine and how a weakened immune system would respond to the vaccine. They wanted information on the effectiveness and timing of the vaccine, so how effective it was for cancer patients, when in the treatment cycle ideally they should have the vaccine, and if it would delay treatment. They also wanted information on the longer term implications. So would this vaccine protect in the long term against the new variants? And would cancer patients need the vaccine to be able to return to participating in support programs? So there were lots of information needs identified through these interviews. In conclusion, we saw generally there was a high motivation and uptake of any vaccine, with those initial minority hesitant who then moved to being vaccinated by the 12 months. This research really highlights the need for consistent and tailored messaging. So cancer patients really want expert advice regarding timing, treatment, interactions, and risks. It highlights the need that GPs might require some education around cancer and vaccinations, and that the confusing and changing messaging from the government throughout the vaccine rollout was not helpful. We have been working with Cancer Australia to provide updated frequently asked question resources based on the information that we have gathered through this research. I'd just like to finish up by thanking the investigators on this project and also acknowledge Cancer Australia as our funders, and also like to thank the participants for their time and willingness to share their perspectives. And I'm happy to take questions.
Thanks, Nikki, and well done on conducting an incredible amount of interviews for that study. There was one question from Kate who's asked, what was the time frame for the interviews? So when were the interviews actually undertaken?
Right, so the 6-month interviews were conducted between March and June of this year. And then the 12 months were from August to October. So really at the kind of start of those waves and sort of the trailing end of the third wave in Victoria.
Yeah, great. Well, thanks so much, Nikki, for sharing your findings. So next up, we have Dr. Bryan Chan, who is a medical oncologist at the Sunshine Coast University Hospital and a senior lecturer at the University of Queensland and Griffith University. And today, Bryan will be presenting on behalf of his multidisciplinary CanVac team, who explored the factors influencing vaccine hesitancy. Thanks, Bryan.
Thank you, everyone. I'd like to thank the organisers for allowing us to present our work. And I'd also like to acknowledge the traditional owners of the land from which I'm presenting today, which is the Gubbi Gubbi people, and pay my respects to elders past, present, and emerging. On behalf of my co-authors, it gives me great pleasure to present our work on exploring factors influencing COVID-19 vaccine hesitancy amongst patients with cancer, a qualitative analysis. As we know, COVID-19 pushed the world into an extraordinary state of rapid scientific and socio-political evolution that continues even today. Global health systems struggled with demands, and cancer care was in no way spared, facing significant delays and disruptions. But early on, vulnerable populations were identified, including those with comorbidities and cancer. This could be due to multiple factors, including potential immunocompromise, the need for frequent interactions with healthcare workers, laboratories, radiologists, etc., as well as the multiple visits or admissions to hospitals and/or treatment centres. In addition to the distress associated with a cancer diagnosis, we also learned that patients had a nearly fourfold increased risk of contracting COVID-19, and that if they did get it, they also faced increased morbidity and mortality. A global race was done to develop effective vaccines, and a tremendous global effort, including $18 billion in the Operation Warp Speed, was invested. However, despite these efforts, the speed and lack of relative long-term follow-up led to misinformation and some confusion at policy level. This ultimately led to some patients either declining or delaying vaccination. The aims of our study were to look at Australian patients with solid tumour or hematological malignancies and evaluate the rates of COVID-19 vaccine uptake, explore patient beliefs, and also the factors that influence their choice around vaccination. Although the study was conducted Australia-wide, and the results I'm presenting today from 3 Victorian sites, including Monash, which is a metropolitan centre, and 2 regional centres being Bendigo and Latrobe. This is a cross-sectional online survey conducted from June to August 2021 of adult patients with cancer from 3 health services, as I mentioned before. Patients were recruited using short message service text invitations if they had an appointment in the upcoming 6 months. This then took them to an online platform which gave them information and allowed them to consent online. Promotional material was also displayed at all the sites that were recruiting, and if patients didn't have appropriate technology, then tablets and/or paper surveys were also provided. Unfortunately, the survey was only conducted in English. However, interpreters and carers were able to assist. The survey was designed with a multidisciplinary team, including consumer advocates, and covered topics such as demographics, cancer history, and self-reported COVID-19 vaccine uptake. In addition, there was a pre-validated Oxford hesitancy scale for vaccination, and also 3 other questions exploring their beliefs about infection, as well as the importance of the vaccine. Patients were given a choice of a 5-point Likert scale, including a do not know option, and free text comments were invited. For the qualitative analysis, comments were imported into Leximancer version 4.5, which is a computer-assisted content analysis program that helps to create visual concept maps by analyzing word frequency and co-occurrences. This is an example of one of the word heat bubbles or visual concept maps that is developed by Leximancer, and uses word frequency and seeding words to develop these bubbles, as you can see on the right. And clusters of frequently used terms and those used together are shown visually. Systematic analysis was performed by 2 independent researchers to look at the heat bubbles, identify repeated patterns and themes, and then backward explore a relationship between patient characteristics and the identified concepts. Verbatim quotes were also used to illustrate the viewpoint. Much like other people who have discussed this morning, this survey was conducted, I suppose, in the heart of the 3rd wave in Victoria, and the timeline being shown here. These are some of the results. So overall, there were 1,073 evaluable surveys with a median age of 62. But as you can see there was a range from young people all the way up to 91. Nearly half of patients were female, and about 27% were from regional and rural areas. The cancer types are broken down on the right, with the most common being breast cancer, gastrointestinal, hematological, and genitourinary cancers, respectively. Bearing in mind that the survey was conducted from June to August 2021, at that time, 84% of people reported a positive intent to get the vaccine. At the time, 10% were still undecided, and about 6% were completely against it. During that time, 26% of people reported having 2 doses of vaccine, about 2/3 having 1 dose, and about 1/3 being not vaccinated at all. Analyses showed that higher vaccine uptake was associated with increasing age, being male, English as a first language, as well as a longer time between diagnosis and also the fact that they were not currently on treatment. Interestingly, only 6.7% of people thought that future infection was definite or probable. And I guess this reflects at the time the relative bubble that Australia was in, giving a false sense of security. These are the results of the qualitative analysis, and these are from 382 patients who provided responses, and of that, 4 major themes were developed, which I'll go through shortly. So theme 1 was that there was a perceived vulnerability, either promoted or stopped vaccination. So while some patients reported that the fear of side effects stopped them from getting vaccination, others thought that their cancer should allow them to get priority to receive it. And here are some reflective quotes. The fear of the vaccine making you feel sicker is a real concern. The fear because you are already ill from treatment, you may be more likely to suffer side effects of the vaccine is worrying, even if it's not true. And another one, I've been terrified of catching COVID-19 from the beginning of this pandemic, and I'm annoyed that I was unable to get my first vaccine sooner. The second theme was about not wanting to risk having a blood clot. Many patients reported that they would have preferred to have Pfizer over AstraZeneca, given that the survey was conducted after the second ATAGI announcement. And that this is because also patients had a perceived risk of increased blood clots due to cancer. However, if not given the choice, some would choose not to have the vaccine at all. So as someone who is already at risk of blood clotting, I'm not interested in having AstraZeneca at all. But on the flip side, if I can get Pfizer, I'll be there as soon as possible. The third theme was about uncertainty regarding vaccine effects on cancer treatment. And some patients, especially those currently on treatment, were worried about the effect of either the vaccine on their treatment or vice versa. So some of the verbatim quotes that are reflective are, I'm concerned that I received my vaccine 2 weeks ago prior to my first chemo, and that it may have affected the way my body responded. This is another one. I do not feel comfortable getting vaccinated while I'm undergoing cancer treatment that has already compromised my immune system. I will not take that risk at the moment. The fourth and final theme was about the lack of reputable health information and support of, on the vaccine for cancer patients, which was touched on by the previous speakers. For many, it was confusing to understand the information on COVID-19 vaccine and cancer, and there was lots of uncertainty, particularly on when, how, and which vaccine, which provided additional mental health burdens for patients. Again, the mental health alone just from treatments is damaging enough, let alone the stress of whether or not to have this vaccine. Another quote was that my GP believes I should have Pfizer to be safe. My hematologist disagreed, saying not necessary to avoid AstraZeneca. As my GP is giving the vaccine, I don't know which one to have. In conclusion, at the time of this study, the vaccine uptake was suboptimal, even for vulnerable patient populations such as those with cancer. Patients with cancer desire clear, consistent, and tailored advice for them, and perceived risks about vaccine side effects and interactions with the disease and or the treatments featured strongly. At the time, one of our conclusions was that addressing the perceived risks and information gaps among patients is critical to overcome vaccine hesitancy in this much needed population. I'm happy to report that since our study was conducted, there's been numerous resources, including Cancer Council, Cancer Australia, Medical Oncology Group of Australia, and including the Victorian COVID-19 Collaborative Group, whose slogan was "Got Cancer, Get Vaccinated." And in addition, for other vulnerable groups, such as culturally and linguistically diverse groups, there have been numerous resources with multiple translations available now. I'd like to thank all the patients and the carers who participated in the CanVax study and also the CanVax collaborative research team, whom I work with. Thanks very much.
Wonderful. Thank you very much, Brian, for sharing your work, and quite clear from both your presentation and that of Nikki Bartley's that this has been a infodemic as much as it has been a COVID-19 pandemic. A question I had was, we know that from the research that hematological cancer patients are more vulnerable to the effects of COVID-19 than people living with solid cancers. Did you find any difference in terms of vaccine hesitancy between those two groups?
Not particularly, because there was such a smaller percentage of people with hematological malignancy compared to solid tumor, and we didn't break it down into subgroups of hematological malignancy. One of the limitations, it is a self-reported survey, so we're relying on appropriate classification bias from the patients to make sure that they are understanding their stage and diagnosis appropriately. There was about 15% of people also from with English as not their first language. So I guess that's a kudos to the carers and interpreters who really helped drive this survey forward and help them to complete them.
Excellent. Well, thank you, Brian. And yeah, great to see those new resources have come through for culturally and linguistically diverse patients as well, to encourage that uptake. Thank you. So I would like to introduce to you our fourth speaker of today, Associate Professor Joanne Shaw, who we know wears several hats. Joanne is the Executive Director of PoCoG and Psycho-oncology and Health Communication Researcher at the University of Sydney. And Jo will be combining her two presentations into one today, and will be speaking on multi-stakeholder perspectives on the impact of COVID-19 on oncology services. Thanks, Jo.
Thank you. And firstly, just wanted to recognise the PoCoG working group who contributed to this work, and particularly Polly Harvard, who conducted the interviews and drove the analysis, the qualitative analysis. So as we've heard already, cancer patients and survivors are at a higher risk of COVID, and if infected, experience more severe symptoms. We also know that within healthcare, we've had radical reconfiguration of services, and this really impacted cancer care with changes in treatments, treatment delays to reduce the risk of immunosuppression, restrictions on hospital visits for both patients and their caregivers, and the scale up of telehealth. And we've had some really great presentations today looking at the experiences in Australia. And this is really important because much of the research has actually really focused on the European and US experiences, which, as we know, have been very, very different to our Australian context. So our study is a longitudinal mixed method study that explored the experiences and impact of COVID-related changes to cancer services in Australia from the perspective of multiple stakeholders. We conducted 3 semi-structured interviews over 12 months, and at each time point, we conducted a very short wellbeing survey. Our participants were cancer patients currently receiving or within 6 months of cancer treatment, caregivers of eligible cancer patients, and oncology health professionals. We used multiple recruitment strategies, so patients and caregivers. We used research registries and also recruited through 2 oncology services here in New South Wales. Health professionals, we used professional organisations, oncology services, and snowballing. And we conducted a thematic analysis using a framework approach. The interview timing corresponded to the waves of COVID outbreaks that we saw in Australia. And I'd like to say that this was planned, but it was really serendipitous that the timing of our interviews really reflected when we had COVID outbreaks in New South Wales and Victoria. Across the time points, we saw about a 25% decrease in participation across interviews. And that was reflected across all of our stakeholder groups. So at recruitment, our patients were 59% of our patients were in current treatment, 38% had been diagnosed in the year of the COVID pandemic starting, and we had about 44% with advanced disease. We did have representation from across Australia, but understandably, given the impact of COVID, New South Wales and Victoria were overrepresented. And not surprisingly, breast and prostate cancer were also the most common cancers that we recruited. Our caregivers were predominantly female, spouses, and again, we did have national representation, but we had an overrepresentation in the COVID lockdown states. Similarly, we had a range of disciplines among our health professionals, with nursing being the most common discipline that we recruited. And majority of our participants were practicing in the public sector. All right, so our qualitative analysis really identified two meta themes that were common to all stakeholder groups across time. Firstly, there was the emotional impact, and this really encompassed fear and anxiety around infection and possible death, uncertainty, and isolation. Our second meta theme related to the healthcare changes as a result of COVID. And this really was around the safety changes, increased stress and loss of support, communication challenges and gains, as well as the quality of care. So I've just got to move the panel because it's interrupting my view. Okay, so in the first round of interviews, fear and death anxiety was really universally expressed across the stakeholder groups. Unsurprisingly, we really didn't know what we were dealing with, so fear of infection and transmission to loved ones was really prevalent in the interviews, and there was a recognition across the stakeholder groups that hospital attendance, either for work or for treatment, placed stakeholders at an increased risk. So there was a sense of mortality and worry around what would happen if the stakeholders were infected. By interview 2, priority vaccination for patients and for health professionals and the continued use of risk mitigation strategies throughout Australia really saw this fear and anxiety reduce. Patients and carers were cautious, but less fearful. By interview 3, health professionals reported that the increasing COVID risk was concerning, and they were fearful for their immune compromised patients. And they were also fearful that as cases rose, that the system would become overwhelmed, and what was the personal impact of that overwhelmed system, and also the service disruptions more broadly. And so this was when we started seeing in New South Wales and Victoria deployment of cancer health professionals into COVID-related roles. So the second theme was uncertainty. And initially, there was a real increased uncertainty in an already uncertain time for patients. There was a lack of information. Telehealth, as it was rolled out, was perceived as difficult, and there wasn't an ability to ask questions, and a real fear of the unknown. And that fear of the unknown was prevalent across the stakeholder groups as we watched what was happening overseas. Again, when at interview 2, we had priority vaccination, and so there was a return to certainty for many. But although the uncertainty around COVID started to decrease, patients started to talk about the fact that what does COVID and delays or changes to my treatment mean for my cancer? And so there was a bit of a switch in feelings of uncertainty from COVID to cancer. By interview 3, we're starting to see higher COVID rates, but we did have vaccination. And there was this sense of, oh, here we go again. And patients really started to ask questions about, what does this mean for my treatment? Unsurprisingly, given that we've all been living in lockdowns, there was a real sense of isolation. For patients at interview 1, when we switched from being able to attend appointments and moved to telehealth, those patients who were actually still going into the hospital felt unsupported. The carers felt excluded because they were often not involved in telehealth consultations, couldn't attend appointments with patients. Both patients and carers were concerned about separation from family and the impact that had on provision of care and support. Health professionals reported that they, because of this, the lockdown strategies and the way that cancer teams were actually divided to minimise risk of whole cancer services being put into becoming close contacts and being unable to attend the hospital, there were fewer strategies to manage the burden of caring. They were also isolated from their families because they wanted to protect their families from infection. However, although this was still going on, there was still a sense of, we're all in this together, we're all supporting each other. By interview 2, with respect to isolation, for much of the country, there was a return to relatively normal. Patients and carers, particularly in the non-lockdown states, perceived that they were more supported, but there was still some apprehension. Health professionals at interview 2 felt a sense of relief for patients and carers. They felt that there was, a return to some sense of normality. By interview 3, patients and carers started talking about feeling fatigued by the fewer supports. When the cancer services changed to telehealth and were really on a crisis footing, much of the supportive care services, the interactions with nurses on a daily basis, and that holistic care had disappeared. Carers were taking on a lot more of the caring role, and they had fewer supports outside of both the hospital, within the hospital and also outside. And health professionals were talking about being isolated from colleagues. They were missing those in-person connections because all of their interactions were on Zoom, and the teams were still divided. So that brings us to really the changes in healthcare. And unsurprisingly, safety was a real issue, particularly at the beginning of the pandemic. Patients and carers were worried about the risk of infection, but they were actually reassured by the safety measures that the cancer services put in place. So they may not have liked the fact that they were doing a lot of telehealth, but they felt safe in that environment. They also felt safe with the level of mask wearing and checking and sanitizing that was going on if they attended hospital appointments. Health professionals, however, were really worried about the prioritization of COVID over cancer and what were the potential downstream consequences for that within their patients. By interviews 2 and 3, where the impact of vaccination started to play out, patients and carers were more concerned about their cancer, and patients in particular were concerned for carer safety. Carers started taking on more of the COVID risk because they were actually out and about in the community, doing the shopping and interacting to try and keep the patients safe. Patients also reported a sense of vulnerability due to the unvaccinated others. And if you think about, the discussions around vaccine hesitancy, and we started to see some of the infections and within cancer services, there was a sense of unease around having unvaccinated people in the community. And by interview 3, health professionals really were starting to worry about the impact of COVID risk with increasing exposures in the community and also within the hospital. With respect to communication, there were both challenges and gains. Initially, when in the first interviews, there was high information needs across stakeholder groups. Their information was changing. It was quickly evolving as we tried to grapple with what COVID meant for the Australian context. Universally, telehealth was perceived as less personal, more procedural, and people were really struggling to work out how best to communicate empathically in this changing environment. However, by interview 2, and particularly by interview 3, patients and health professionals were generally happy with telehealth. They could see the value of telehealth, but they did report that there was some variable quality. And so there was discussions around whether or not telehealth should be used universally for all consultations or just for some consultations. Clinicians were very much worried about the fear of missing something over telehealth, so a cancer recurrence, because they were unable to do a physical exam. And there was this perception that there was a lack of telehealth training. I think one of the issues with telehealth is that there was a lot of rollout of the logistics of how to use telehealth, but some of the communication challenges and training around communicating with telehealth really weren't covered. For many patients, the flexibility of telehealth was recognised, and it wasn't just about being protected from COVID, but also just the freedom to be able to attend appointments from your living room or not having to travel from the regions was seen as a bonus. The next thing was quality of care. And at interview 1, the treatment changes were an issue for health professionals because they were actually the ones implementing treatment changes to whether it's the chemotherapy regime or the scheduling of appointments. And they were really concerned about the negative impact in the longer term of these changes to treatment because it was perceived as a move away from evidence-based care, but a necessary evil, I guess. And patients were less concerned about, or they didn't perceive that there were major changes to the quality of care, but they did start to ask questions about future care and the longer term consequences. Both patients and carers really reported missing that nursing support, missing that supportive holistic care. And so although they weren't necessarily overly concerned about cancer outcomes, they were concerned about the psychological outcomes of not having that supportive care in place. By interviews 2 and 3, stakeholder groups universally really were starting to talk about the impact of cancer care. Those that had had procedures or tests delayed were starting to wonder whether or not, a tumour had been missed because they hadn't had their follow-up. The health professionals were concerned that patients were avoiding hospital to reduce their risk of COVID. When they did come, they were presenting sicker, which meant that it increased the workload for the health teams. And, patients were actually having poorer outcomes because they were delaying their treatment and side effect management. By interview 3, the health professionals were really quite concerned about the fears of late presentation as well. So having elective surgeries and biopsies cancelled, screening in some states was either delayed or cancelled. And sort of in the last few months, there's been this backlog of cases are starting to really present. And so they were seeing a lot of new diagnoses that are more advanced than what we would have expected. And there's a large influx of referrals for, say, psycho-oncology, as people are being diagnosed with more advanced cancer. So all of this really highlights the increased stress related to the loss of support. So again, as I've talked about before, patients felt isolated because there's no supportive care. They were isolated from families. Carers were isolated both from interacting with the health system, and they had limited social support because of lockdowns. Health professionals reported loss of support because of the higher workloads, longer hours, and the impact of COVID on staffing. So they were experiencing increased stress. And by interview 2, patients and carers were reporting high fatigue. They said that there was still a lack of support. The services hadn't gone back to the high level that they had been prior to COVID. There was a lack of social support, and carers in particular felt that long chronic fatigue. They're also noting that that health professionals were fatigued, and they were concerned about, if I've got a health professional who's stressed and worn out, what does that mean for my care? Is that going to impact negatively on their ability to provide the best level of care? And by interview 3, health professionals were reporting not just fatigue, but exhaustion. The hospital-wide changes to care, the fact that even in states where there were no lockdowns, leave had been cancelled and changed. There were changes to staffing. And there was this increasing worry and dread about late presentations. And so as the pressure was mounting, as we're seeing more patients with more advanced disease, we're tired already, and what's going to happen in the future. And so this was really obvious in the wellbeing survey that we did. So overall, patients had maintained low levels of anxiety and depression throughout the 12-month study period. The initial period, the initial anxiety and depression and stress that was seen amongst carers in the first interviews decreased in the second interviews. But by the third interview, we can see that stress was increasing quite dramatically again. But it's really the health professionals who really demonstrated the impact of changes to the system. We saw increased levels of depression and continually high depression across the continually high stress across the 3 time points. So if we think about the themes that we identified and tried to map them conceptually, overall, our participants were really trying to balance fear and safety. They were trying to navigate evolving uncertainty in an ever-changing situation. And they were experiencing fatigue due to lack of support and that sense of isolation. And for health professionals in particular, there was this growing sense of dread of what was to come. And all of this is having a real emotional toll on our cancer stakeholders. So for patients and carers, we saw over time, the initial heightened fear and anxiety was maintained by some, but the chronic stress and fatigue started to result in a sense of resignation or despondency. And as I said before, they were really aware of the impact of the high workload and anxiety that health professionals were experiencing. And they were saying that, they seemed to be stressed and overworked. Similarly, health professionals, that initial anxiety evolved into feelings of being overwhelmed. There was, for some, that was despondency, and we started to see features of burnout, such as emotional exhaustion and lack of personal accomplishment. They also reported low mood within the workplace and a resignation to the fact that there was little chance of a break. So in conclusion, COVID compounded the impacts of cancer. Caregivers in particular require additional support, and we need to think about creative strategies to include carers in consultations, because that will help to reduce patient distress, but also help to support our carers. Health professionals are exhausted, and support for the next wave of delayed presentations is crucial if we're to retain our oncology workforce. And overall, although the quality of care was maintained during COVID, system-wide rollout of telehealth was seen as a positive innovation, but we need to look at training, particularly around eliciting emotional concerns and space for open discussion. We need to think about better provision of supportive care, and we need to seriously think about service level planning to manage increased workload. So thank you.
Thank you, Jo, for sharing your insights from that rich qualitative data that you gathered, and some clearly real concerns there for both our patients and our healthcare workforce that we need to prioritise as we continue to be challenged by this COVID-19 pandemic. A question that I had was that you mentioned that telehealth was perceived as less personal. Did you find that either patients or clinicians talked about their experiences with having difficult conversations via telehealth? So I guess, for example, discussions about sexual concerns or even death and dying.
Yeah, so initially when telehealth was rolled out, the consultations were very much information provision. They were very procedural, and so difficult conversations really didn't happen. And then over time, the fact that patients felt the inability to have open discussion and ask questions really started to impact on them. But then the health professionals also reported the fact that they recognised that they were potentially missing emotional cues. So the things that in consultation, face-to-face consultations, the non-verbals that would prompt them to ask about, is there something worrying you? Is there something that, you would like to discuss? Or they weren't able to use those cues to guide conversations. So they too were concerned about it just being provision of information.
Yeah, thanks, Jess. Really, really tough. And I can imagine as well, even face-to-face at the moment with all that PPE on, that, that creates a physical but also an emotional barrier. There's a question here from the audience, whether you've published your work and whether we might be able to access that.
So we have 3 papers, 2 under review, and the third paper, that sort of the conceptual framework that we've developed, we'll be submitting hopefully tomorrow, in the next week or so. So the papers are all under review and will hopefully be available early in the new year.
Great. Well, we look forward to seeing that. And just we'll take this one last question from Sarah, who's asked whether any of your questions asked about lack of support from cancer patients who have no support or rely on an interstate relative to support them, who've been unable to see each other due to lockdowns.
Yes, and it's not even just interstate travel restrictions. Even within Melbourne, not being able to travel outside the zones, or having carers in regional areas who were prevented and not given permits to travel into the metropolitan area. The other interesting component of that was that patients often elected not to have their caregivers, their family come and care because they were concerned about transmission. So they struggled in isolation rather than having their carers come into a high COVID hotspot. So yes, there was a lot of, I've sort of glossed over it, but yes, there was a lack of support for those with non-residential carers.
Yeah. Great. Well, thank you so much, Jo, for sharing all that knowledge. So I would like to introduce to you Dr. Claire Cooper, who is working both as a research manager at PoCoG and a clinical psychologist. And today, Claire will be talking about the wonderful work she has been leading in developing psycho-oncology telehealth recommendations. Thanks, Claire.
Thanks, Ninka. I'll assume you can see and hear me properly, but yell out if not. So thanks everyone, my name's Claire and today I'm discussing the development of the psycho-oncology telehealth recommendations, which I'm presenting on behalf of a large and wonderful PoCoG telehealth advisory group. I'd like to begin by acknowledging the traditional owners of the lands which I'm joining on today, which are the Darramaragal people, and I pay my respects to elders past and present. For many psychologists working in oncology, it's been a challenging couple of years, as we've heard through the last presentations. The impact of COVID-19 can't be understated for all those receiving or providing healthcare in the health system. To protect those living with cancer and due to lockdown logistics, both patient and clinician needed to move to telehealth rapidly, whether they felt prepared or not.
Claire, you haven't shared your slides.
Thank you. Right, we'll try this. Is that working?
Yep, you just need to flip your screens because we've seen your notes. So,
yeah, perfect.
Yep.
Okay. I will briefly run through where I was up to. Okay. So clinicians have reported feeling unsure about the quality of the telehealth service they are providing and how much benefit they're affording the patient. What is clear from the research, however, is that they're doing a great job. So some of the concerns that clinicians have raised about using telehealth are things such as whether their clients are getting benefit, how other psychologists are doing telehealth, what happens to the Therapeutic Alliance doing telehealth, and whether they should continue using telehealth. So the aim is that with the addition of the psycho-oncology telehealth recommendations, that it will show the effectiveness of telehealth to clinicians, provide guidance on how to adapt therapy for telehealth, provide evidence to the clinicians that there is a high level of acceptability around the Therapeutic Alliance for patients using telehealth, and hopefully an increase in confidence to keep using telehealth. So I'll cover why there's a need for psycho-oncology telehealth recommendations and give you a little bit of information about the co-design process and main outcomes of this, and then some conclusions and the next steps. So that, as we've talked about, there was a rapid implementation of telehealth triggered by COVID-19, and there's clear evidence of the effectiveness of telehealth and that there is client satisfaction in using telehealth. So in 2021, PoCoG did a study investigating barriers and enablers to using telehealth. And one of the findings was the need for guidance in adapting therapy approaches for telehealth, psycho-oncology specific for clinicians, which was also widely supported in the literature. There was, however, limited guidance on provided in the literature in how to adapt specific interventions in a telehealth environment, really to optimize the patient experience. So there's existing information which focuses more on the practical, ethical and legal considerations, which we do acknowledge are obviously very important in a holistic document that's providing guidance. So we do provide information on all of those aspects as well. But our focus and the point of difference, I suppose, is really that we wanted to focus on that how to do the adaptations. So an extensive review of the literature was undertaken, and then we put together a stakeholder feedback expert advisory group with 14 members, so comprising of clinical psychology, range of psycho-oncology clinicians, health communication, education experts, telehealth experts, and through clinical scenarios, self-reflection exercises, clinical guidance, reviewed for clinical relevance, we put together that consensus process. So in terms of the co-design approach, group collaboration and creation of material, multiple rounds of review, input, editing, expert-specific clinical input, and then further review by the advisory group. And then that process allowed us to keep coming back to identify any gaps in any of the sections or in the document as a whole. So the co-design approach identified key recommendations around adaptations to therapeutic techniques, clinical practical strategies, communication strategies, maintaining the therapeutic alliance, and managing varying patient presentations. So in terms of the clinical considerations over telephone and video conference, as you can see there, I'll go into a little bit more information around the formulation and comforting a client, just to give a little bit more detail, and also the practical and logistical issues. As you can see there, some of those issues are as detailed as things like setting up the camera, how far away to sit from the camera, lighting to get optimal visual image, privacy considerations such as screen sharing and how to ensure personal information or email and whatnot isn't shared when you're doing screen sharing. So just to delve deeper into a few of these aspects to give a bit more detail, things such as comforting a client are really important to consider when doing telehealth, as being quite different to in-person therapy. So some of the considerations are challenges in identifying emotion due to physical distance. It's easier to miss cues of discomfort and emotions such as tears welling in the eyes of the patient, and reduced options for comforting. So some of the, sorry, just move the panel. Some of the recommendations that we suggested were things along the lines of discussing and normalizing, providing, and also acknowledging that the clients might feel a bit more exposed or confronted while they're becoming emotional over telehealth, reassuring them that they're safe and really encouraged to experience and display these emotions just as they would in face-to-face. The recommendations provide some scripted examples around how you might address these issues. And also the absence of visual cues is a really big one. So there's a need there to rely on non-verbal cues like pace and pause and tone. And it might require more frequent and open check-ins with the client about how they're finding the session, how they're coping, just how they're going. Generally, you might be checking in a little bit more than you might in face-to-face where you have those cues. Some of these things are similar to when we're talking about encouraging the therapeutic alliance, which I'll talk about in a few slides' time. Another example, providing a formulation. So this is something that's an important part of therapy and can be quite detailed, and really it's useful to have quite a collaborative approach with the client. So when thinking about how to get across a large amount of information or get their input on that, we looked at various options that people might take. So if you're using video conference, but in a really basic form, so just acknowledging that you've got the camera there, but none of the bells and whistles, how you might do that. So considering emailing information before or after the session to complement what you're discussing with the patient, or things like if there's basic images and text boxes, making those bold with the text, or if you plan on holding it up to the camera, just so that it's easier for the client to see. For example, advanced video conference. So if you're considering different apps, and there's a range of different types of technology that can be used, like taking a photo or scanning and sending it via an app to email in real time. That might be something that people use, or the screen share and whiteboard function to share information, to get the client to annotate, that sort of thing. So provide a little bit of information on that. And then if the formulation is being provided by a telephone, again, potentially emailing documents or information before or after, or acknowledging that people using the telephone might be doing so because they don't have internet access. So it might be as simple as getting them to have a pen and paper handy so that they can write down the basic information or a summary or keywords, just something tangible that they have when the session's over and a large amount of information has been shared, so that they can go back and remember the points of treatment and where they're going with treatment. In terms of maintaining the therapeutic alliance, the PoCoG study, I'll let you read those quotes, but identified the importance of identifying and working with clinician concerns. So as I've said, there is a large body of evidence that shows the effectiveness of telehealth, and that the therapeutic alliance can be just as strong in telehealth as it is in face-to-face, but a number of clinicians aren't necessarily aware of this. And so working with them, to provide that information, to build confidence that it is an effective means of therapy, and also that the therapeutic alliance is not negatively impacted. And then to provide, as you can see, some tips on fostering that therapeutic alliance and demonstrating empathy, things like verbal and non-verbal gestures, checking in with the client, as I said before, a little bit more frequently, and camera use. So for example, looking at the camera maybe more than you otherwise would in a Zoom call, so that you're looking at the patient. So some of the adaptations to therapeutic techniques. So for CBT, I've already mentioned a few of these around sharing resources. For the behavioural therapy examples, there's some case studies which I'll quickly go over in a minute, and some clinical examples. And then for ACT, things such as sharing visual resources, screen sharing, some examples about how you might do metaphor work over the telephone and video conference. So we've tried to include a number of different examples across a number of different therapy types, acknowledging that clinicians will be coming from different frameworks, and that it's definitely not a one size fits all. So it's more about application of these ideas and concepts to the type of therapy that the clinician is used to using. So just a few examples, just screen grabs from the document. So if you're doing ACT values bullseye, you might be wanting to have a texter there to make the lines really bold to hold up to camera, so that you can use that as an example, even if you're not filling out the exact details in the session, just holding up a bit of a guide for what you're talking about. In terms of simplifying information, so again, instead of describing the detailed hexaflex for ACT, you might describe the simplified triflex. So it's just similar information, but in a simplified form, if that fits the purpose. And so you can either draw that or write that and hold it up to camera. You might be able to annotate on a share screen whiteboard, or it's just verbally easier to describe 3 points of a triangle than it is to try and go into the other one. So we just provide some examples like that. Again, screen sharing just provides some examples about how you might do that, excuse me, and why it's important to have that information separate, so that there's not the privacy issues of bringing up files or emails or anything like that accidentally. And then there's some really good detailed case studies in the document. So for example, and it also, the case studies really bring together a lot of the clinical recommendations and content that's referred to during the presentation. So for example, a case study around mask anxiety, and how a clinician might approach that via telehealth without access to the usual things that you might do when you're doing systematic desensitization. So for example, you don't have access to the mask or being present in the radiotherapy treatment space. So how can you do desensitization to the mask via telehealth? So some really practical suggestions around things like that. And for example, there's an end-of-life care case study, some of the challenges that this can bring, and also some of the benefits that this has been mentioned previously, the flexibility of telehealth can afford. So maybe continuity of clinician if the patient needs to go elsewhere or they're too unwell to come in person, but they may be able to continue seeing the clinician via telehealth. So next steps will be a formal national Delphi process, which will be undertaken with clinical psychologists working in oncology to strengthen and refine recommendations, and to gather consensus through rounds of questioning. So I'll be doing a bit of a call out in the new year for expressions of interest for that. So stay tuned, and then potential for clinical utility and feasibility studies in the future. So in conclusion, we've identified a gap in the literature, and we're creating an expert-endorsed guiding document to increase sustainability, implementation, and confidence in telehealth. And a big thank you to the PoCoG Telehealth Advisory who have helped to bring this all together. Thank you. And apologies at the start. I don't know what happened. Didn't do that in practice, but it's all right.
Thanks for your presentation, and a great example also just of the good things that have come from this pandemic. It's a really great initiative and look forward to seeing it being implemented into clinical practice. Obviously, you know, with this telehealth modalities have increased access for regional remote patients, but I suppose telehealth can also be less suitable for culturally and linguistically diverse patients. So, you know, what can we do to make sure that these telehealth modalities don't exacerbate disparities for those groups?
That's a really good question and a really good point that we're really aware of, and trying to include content in the recommendations around working with culturally and linguistically diverse populations in terms of, first of all, just acknowledging that there is that potentially that disparity there, and having those open discussions about what mode of telehealth is accessible, what's realistic, how can we maybe adjust what the plans were to meet a patient with what they're able to get access to. And then we're providing information around things like working with interpreters via telehealth, and a few different examples of how that might work via different modes of telehealth. But it is a really important issue, which we touch on, and hopefully providing a few different examples, and just also acknowledging that that is something that needs to be considered in all consultations.
Yeah, fantastic. Thanks very much, Claire.
No worries, thanks.
Okay, so it's my pleasure to introduce to you our final speaker of today, Sarah Smith. And Sarah is a medical student at the Port Macquarie campus of the University of New South Wales, and she has a very keen interest in oncology and regional communities. And today, Sarah will be presenting her findings from her honours project, which explore the perspectives of patients, their caregivers and clinicians regarding telehealth services during the pandemic. Thanks, Sarah.
Great, thank you so much for the introduction. And can I just confirm you can see my face and also hear me and see the slides?
Yes.
Perfect, alrighty. So yeah, thank you. I'm Sarah, I'm one of the medical students in Port, and today I'll be presenting my qualitative research on oncology telehealth experiences during the COVID pandemic, which was under the supervision of Dr. Ben Smith and Dr. William Kennett. So just before I begin, I would like to acknowledge that I'm joining this meeting from the lands of the Biripi people. And I also acknowledge the traditional custodians of the various lands on which you are all joining from today. I pay my respects to their elders past and present, and I extend that respect to any Aboriginal and Torres Strait Islander people participating in this meeting today. So as we've heard this morning and this afternoon, the COVID pandemic has had significant impacts in oncology. With pandemic restrictions limiting close contact between individuals, telehealth has been increasingly used. Telehealth can be defined as the use of technology through phone or video to have real-time medical consultations. But there are several limitations in the current oncology telehealth literature. So firstly, limited research has been conducted in urban populations. Secondly, studies rarely explore patients, clinicians, and caregivers' perspectives simultaneously, making it difficult to compare views. And thirdly, most studies have explored the use of telehealth prior to the pandemic. Qualitative studies are valuable as they can shed light on the factors underlying the broad acceptability of telehealth found in the quantitative studies. So the objective of our qualitative study was to explore the first-hand perspectives of telehealth use during the pandemic in participants from urban and regional backgrounds. So study participants were cancer patients, their caregivers, and treating clinicians from Liverpool and Port Macquarie who completed a semi-structured interview. All participants were English speaking and had used telehealth since March 2020. All participants provided voluntary informed consent through either written or online means. And NVivo 12 Pro software was used for thematic analysis, and this occurred simultaneously to data collection. And the interview ceased when data saturation occurred. After we transcribed the interviews, we generated codes, which were then grouped into larger sub-themes and major overarching themes. So as you can see from this slide, 52 people were invited to participate in the study, with 34 people completing interviews face-to-face via phone calls or video calls. And the main exclusion reasons were no reply and no interest. The participants varied in age, and there was a majority who were born in Australia. So as you can see from this table, the patients had a variety of cancer diagnoses. Caregivers were either spouses or a child of a patient, and the clinicians were from various medical, allied health, and nursing backgrounds. So now in this figure, you can see that we found 7 major themes from the thematic analysis, and I'll briefly go through each of these with some illustrative quotes. So this first theme reflects how participants generally viewed telehealth as an acceptable temporary solution and an appropriate form of consultation. However, some did express dissatisfaction in situations where they felt a face-to-face consultation may be more appropriate. And this is illustrated in the quote from caregiver 6, "Bad news is better face-to-face." Participants also discussed the positive and sometimes negative effects that telehealth can have on their mental and physical comfort. This second theme highlights the impacts of telehealth on different aspects of cancer care. So some clinicians felt that their approach to telehealth consultations was different than those conducted face-to-face, and they acknowledged the limitations with physical examinations, providing paper resources, and the inability to show test results through telehealth. This is demonstrated in the quote by clinician 13, "It's not the same medical assessment as seeing the patient." Most patients and caregivers believe that telehealth provided the same quality of care when compared to face-to-face consultations. However, when we talked with the clinicians, many of them felt that the quality of care through telehealth was different, even suboptimal, and you can see that in the quote from clinician 11 at the bottom of the slide. So this next theme highlights the strengths and weaknesses with communication and relationships through telehealth. Whilst many experienced no communication problems, concerns were raised over those with hearing impairments, the lack of visual cues with telehealth, and the use of phone interpreters for non-English speaking patients. The relationship between patients and clinicians was also raised. Some clinicians commented on the difficulty of establishing rapport, as illustrated in the quote by clinician 9, "I kind of feel like there's another layer of that building rapport that's missing." Patients and caregivers also commented on the impersonal nature of telehealth, particularly with the phone only. Participants also mentioned that telehealth allowed the involvement of extended family, something which is not always possible in face-to-face clinics and appointments. So theme 4 outlines the efficiencies of telehealth as a form of consultation, some of which have been touched upon earlier today. So many found telehealth to be convenient, causing minimal disruptions to their daily routines, but clinicians did comment on having sometimes increased but also impaired workflow and flexibility. Patients and caregivers also mentioned the cost and travel savings of telehealth, as seen in the quote from patient 6, who appreciated the bulk billing of telehealth consultations, especially as they were a pensioner. The participants also had mixed experiences regarding the logistics of telehealth, and they raised issues such as confusion around appointment times, difficulty contacting the hospital or cancer clinic, and the inopportune timing of some telehealth appointments. So this 5th theme reflects the comfort of conducting telehealth in different environments. Patients and caregivers frequently commented on the benefits of having telehealth in their own comfortable surrounds at home. Clinicians worked in different environments, including in hospital, in clinics, as well as at home. And those who worked in shared office spaces, though, commented on having background noise and sometimes privacy issues. Many people describe telehealth to be a safety measure, preventing them from exposure to COVID-19. And this is demonstrated in a quote from a caregiver who felt much more comfortable having telehealth at home than going to their spouse's consultations at hospitals, which were experiencing COVID-19 outbreaks. So theme 6 recounts the technological barriers some participants encountered with telehealth. Some participants lacked confidence in the technology and acknowledged having low technological literacy as a barrier for trialling video telehealth. And this is seen in a quote from patient 7, who describes feeling more stressed if they had to use video platforms such as Zoom due to lacking confidence in video technology. Other participants had issues with poor internet and telephone reception, as well as having security, confidentiality, and privacy concerns. Clinicians also commented on the issue of hospital phones calling from private numbers and how this created additional obstacles when trying to contact the patients. So this final theme demonstrates future preferences regarding the use of telehealth. Almost all participants expressed a preference for a combination of telehealth and face-to-face care or work, but only 2 caregivers preferred face-to-face only care for the care of their spouses. Some described situations where video or phone telehealth were more appropriate. And importantly, the clinicians highlighted the need for adjustments to current telehealth practices. Some of these include removing private hospital numbers, providing training or guidelines for online consultations, and selecting specific patients only for telehealth. And this selectivity of patients is reflected in the quote from clinician 6 that you can see on the screen. I definitely think there should be an ongoing role for a well-defined subset of patients that might fit certain criteria. So what do these findings mean? Well, generally, the rapid uptake of telehealth during the COVID-19 pandemic has been welcomed by all. And there are several factors which will enable the continued use of telehealth in future cancer care. And these include the general satisfaction of telehealth as a form of consultation, the positive effects on mental health by having appointments at home rather than going to a hospital or a cancer clinic, the time, cost and travel savings, the ease of access to medical care, especially during the hardships of a pandemic, and the decreased exposure to COVID-19 by having telehealth appointments at home. However, we also must consider that there are some barriers which need to be addressed before telehealth can be more widely used in future cancer care. And these include the lack of appropriate workspaces, technology and training for clinicians. And in some cases, this technology and training needs to be provided to patients and caregivers too. Hospitals calling from private numbers, thus preventing patients from promptly answering calls. The inadequate technological support for online interpreting services, and the inappropriateness of telehealth for some situations and patients. So just to finish up, future research could look into strategies that can overcome some of these barriers, such as the utility and effectiveness of video telehealth training and the importance of having designated telehealth workspaces for clinicians. Also, as our study was only conducted in English-speaking people and as clinicians raised some issues with using telephone interpreting services, it would be of clinical value and significance to repeat our study in a non-English speaking cohort. This group of people may experience unique challenges which should be researched and published in literature. Also in our study, a majority of participants used phone telehealth only, as this was often the only modality offered to them. So therefore, it may also be worthwhile to explore more video telehealth perspectives in future research. So thank you very much for your time today. And I'd especially like to thank my supervisors, Dr. Ben Smith and Dr. William Kennett, and I'm happy to take any questions.
Excellent. Thank you very much, Sarah. Wonderful work you've done there. Just a comment here from Brian, might just say is that he said, I'm currently in between patients in my rural outreach clinic, and patients and carers love that they don't have to travel. I agree with your findings, removing those barriers, but agree Colton interpreters is difficult. Perhaps telehealth interpreters in the future.
Yeah.
Yeah, it was interesting as well. You mentioned, they do like telehealth and they wanted to stay beyond the pandemic, but there were also some challenges that related to the human factors, such as building a report rather more than the technical aspects.
Yeah.
What are some of the things that we can do to, I guess, make telehealth more human beyond the pandemic? What are your thoughts?
I think probably the use of video would be really beneficial. So as I said, most of the participants only had access to telephone telehealth, but I think having that video telehealth would be really beneficial, just to be able to look at the person you're talking with, see their kind of facial features and how they're responding to comments that you're saying, even things like screen sharing and showing results. So I think that personal kind of interaction with patients can be developed better through a video kind of telehealth system. So obviously there are challenges in that, technological, and being rural, sometimes there are issues with that, but yeah, that would probably be a first good step if that could be more rolled out and universally used.
Yeah, absolutely. Well, great work, Sarah, and look forward to seeing you continuing his work also in the regional and remote communities that you hope to work in. Thank you.
Thank you.
So that actually brings us to the end of today's presentations, and I want to thank all our presenters and our virtual audience for tuning in today. And also just a reminder that we will have our final webinar tomorrow on fear of cancer recurrence, and we hope you can join us. So thank you.